when I did the test to him, there wasn't one eye movement that he was capable of doing.
You're delivering miracles, Dr. Schneider. You're delivering miracles. If we told people that we just made this change and showed them this data, they would go, "Oh, that's not possible." But it is possible. I'm going to show you what you couldn't see before. We're going to be able to see diseases and pathology years before they arrive.
Dr. Kitterman's like 77 and he looks like, 57. I think that I'll stay young the more I learn and the more I participate.
Welcome to My Pods Podcast. I'm Dr. Joe Schneider, and after 35 years as a functional neurologist, a personal journey through stroke recovery, and helping thousands of patients, I'm here to share breakthrough solutions for POTS and neurological wellness. From getting out of bed in the morning to rebuilding your nervous system, this is your guide to understanding and overcoming neurological challenges. Let's begin this journey to recovery together.
Hello, I'm Dr. Joe Schneider, and I am the host of My Pods Podcast. And I practice here at the Hope Center in Chatsford, Pennsylvania. And we're talking tonight with Dr. Freddys Garcia, a good friend of mine for years, a fantastic professional and clinician. He's got a new position now, which I'm so supportive of, with Spryson USA. And I've become part of the Pioneer program. So the technology already we have part of it in the office will be continuing until it's complete this fall. Freddie, the topic today is going to be...
It's going to be the use of technology in concussion rehabilitation for the modern clinician, what that looks like.
Yes. Now, I've been doing technology since 1989. Like whatever technology came out,
You've been
I
big
bought
on
it.
that.
I applied it. I played with it. A lot of times I never got paid for it, but I still did it. And I recognize that when we do a bedside test, right, that we can't accurately pick it up. But with the advent of like really supercomputers, and we're able to do so much as far as measurements concerned, that baseline and moving off a baseline has become very, very important. So tell me about your experience in that kind of bedside versus technology, and why going in that direction is more beneficial, not for the practitioner, but for the patient itself.
All right, awesome. So I'd love to jump into this because this is something I'm spending the last few years. I've always loved technology. My first job out of college before I became a clinician and a physician was in IT. I used to be a programmer for insurance systems. So I've always loved computers and stuff like that. So that I landed at Spryson as VP of clinical success has been wonderful because now I get to work with engineers and software developers and researchers and take that information, apply it to clinicians. Then I get to talk to brilliant clinicians like yourself and go, hey, what do they need to become even more amazing clinicians? And I get to bring that back to Spryson and create amazing platforms. And we think we're doing that in spades. But you asked a very good question. You kind of go, hey, this transition from the bedside to the more high tech, or, I say mid tech and then high tech. My eyes have really been opened as I spend more times with a certain group of people. And I'll tell you, the group of people is the researchers. Because I'll go to them and I'll say, hey, listen, I want to create this neurovisual training in the goggles, which Spryson could do in their DX200 goggles. Spryson has these cool goggles. They're 3D virtual reality, and they do VNG, video oculography, and eye tracking all in one platform. But you also can do training in them because they could do, they give you optokinetic training, they can do different dots, different complex things, and it's 3Ds. You can do Virgins training. So for the doctors listening at home, they know what I'm talking about. So that becomes really, really cool. But I would ask them to go, hey, I want you to create this montage of protocols for me. And they would go, Dr. Garcia, why? What would you need to see that we know that some patient would need this protocol? And I would say, okay, I would see this on my bedside exam, and I would see this on my physical exam. And they would go, no, you don't understand our question. They go, what data would you need to see coming out of these platforms to know that the patient needs this protocol? And I had this realization. I go, it's not that they don't discount my bedside examination. There is value in the bedside examination. The value is that I get to see gross asymmetries. The value is that I get to see markers that are not within normal limits, and they're obvious, right? But when you get to the minutia of those values, you need a perfect data acquisition machine. And that's where technology like a VNG that Spryson makes, and there's other makers out there, but I believe Spryson makes the best one in the world. That's why I'm aligning with them. It's perfect data acquisition. I mean, they're operating at up to 250 frames per second, capturing data. That machine can see what our eyes cannot see when we're asking a patient to follow our thumbs back and forth. That becomes very exciting because.
Well, let's go through it. So for the general public that's watching the podcast, I mean, that's mostly who we're going to do, but there's different eye movements. One is a smooth pursuit where you just pursue something moving slowly, or it can move much faster, and you can not only match the eyes if the eye is following it. And then you can do it horizontal and you can do it vertical. But what I've been using more now since the master class is the gaze. We're looking at the gaze, whether it's focused, what's in the dark, it's in the light, and watching eye movements, right? It's like spontaneous nystagmus, square wave movements, things like that. Man, it gives us like so much information, okay? So when I got back from the seminar, I have an 18-year-old kid that has autism. And I question whether it's really autism or not. His eye move, when I did the test to him, there wasn't one eye movement that he was capable of doing. He was so far out of norms that I really got concerned that I could like even pull him back into norm. So we did our first retest. And what do you think's happening? So we had the goggle, and we used the goggle for rehabilitation. I would say that he's about 60% rehabilitated with his eye movements. And little things like he's looking at his phone. He's doing more things with his phone because he actually can see it. He can see his phone. Like, can you imagine a kid who's not social? He's afraid to socialize with people. He gets aggravated all the time. He gets motion sick. And when he's in the car, his parents don't know what to do with him because he's going crazy in the car. And now he can look at his phone because he can do all the simple things that we're testing with the goggle, right? Now, I've had kids like this before, but I couldn't see the improvement. I mean, I couldn't numerically look at what the improvement was.
Get that objective number and say, you could literally say he's 7% better today than yesterday. Right?
Oh, definitely. Yes, exactly.
Even all the components, right? Like, so Joe's talking about some great things. He's going, and now I could look at the eye, and during a smooth pursuit, when you do it within the goggles, you could say, hey, are the eyes jumping in front? Are they jumping behind? The percentages of each. When he goes to one side or the other, is there torsion in the eye? But when he goes in the other direction, there isn't. Those are things that are, some of those are literally impossible to see with the naked eye. If somebody tells you they
definitely.
can see, unless it's a superhero from a Marvel movie, that stuff is like to look at a blood vessel while you're moving your thumb and look at. So that's why it's called bedside examination. And there is value in that. You get to see these gross asymmetries, but the level of detail that you're aiming for to give the level of care that you strive to give, it requires, I would say, inarguably requires technology to really capture that data so you can make better decisions. By the way, that's incredible that you're able to do that with that patient. That's amazing.
And he's a good kid, like really, really good kid. You know what I mean? And so when he starts getting his basic abilities back, it changes his whole reality of living and his relationships with people and his ability to communicate. He doesn't become as insecure. So it's kind of great to see, when I see that in the practice, it just thrills me and, makes me want to get to a point where I never retire from clinical aspects of practice, ever again. People are like, oh, it's getting research. I'm like, oh, yeah. clinical research. Like, just
Yeah.
work
Well,
with
you like the
patients.
miracles because you're delivering miracles, Dr. Schneider. You're delivering miracles. Hey, let me bring up a point to everybody, just in case this is the first time that they're listening to the show. Hopefully, they're longtime listeners. But why do we care about these eye movements? The reason we care about these eye movements is that we're using those eye movements as a biomarker of health of different areas of the brain, right? So if you study your neurology, your neuroscience, like Dr. Schneider has, you could look at pursuits, saccades, all these different reflexes, and you know what they represent in the brain. So one part of the brain could be parietal lobes, frontal lobes, different areas of the brainstem. Is it higher brainstem function, lower brainstem function? Is it part of the integrators that are holding on to movement too long or getting rid of it too quickly? So we're using eye movements, not because we're fascinated with eyes like optometrists are, we're thinking about acuity. We're fascinated with eyes because it's a window into brain health. And when something goes wrong with the movement of the eyes, and you could really see it and capture it and get beautiful data, it points you exactly where to work with that patient. And I think people need to make that connection, and why we're kind of enamored with the use of technology, because now we're seeing what we couldn't see before. When I start showing people this technology, I go, I'm going to show you what you couldn't see before. And then I'm going to show you how simple it is to do the next couple steps, because without a target, it's difficult to aim. They want to make the patient better, but they don't know what to do to get there because they don't have a good target. And to have a good target, you need to know what's decompensated. Does that make sense?
Well, when Dr. Kitterman, who designed most of this technology, when he got on, he basically showed me that when we were doing the goggles, that you could test, real simple, fast test, treat it, and then see immediate results, immediate changes going on with the eyes, right? And that's like in a clinical practice, that's so important. It's like you don't want to wait a week to see changes. Like you're going in the right direction. Am I going the wrong direction? Okay, well, I made the wrong turn. I made a left instead of a right, and now I got another hour trip to get back to the center again, right?
I've been guilty of that when listening to a good podcast, though. So it's no, you are absolutely correct. People, I think clinicians sometimes they're afraid of the technology because they go, is this going to slow me down? And what I tell them is I go, listen, when you know how to leverage this technology, it actually makes you quicker and at least Spryson has done a good job about thinking about the clinician's workflow. And also by working with pioneers as yourself, we're taking your feedback very much to our hearts and immediately bringing that back to the engineers, bringing that back to the software developers and making changes. So we actually have some great progress we're making in protocol creation because we want to go even faster from assessment, training, and then reassessment. So in that session, you should know that the patient made a 15, 30, 40% improvement. You don't have to wait 2 weeks and go, did I do the right thing? We know because we're capturing that data and we could see the things that are kind of hard to see or sometimes impossible to see with some of these other tests. And again, not discounting bedside examination. It's important, but it's really for gross asymmetries and some grosser pathology. Now, there's tiers to the education, Dr. Schneider. I'm sorry, not to the education, to the technology, which requires education. It really, really does. You have to really know what you're doing. But once you go past goggles, one of the pieces of technology is going to be arriving in your office this fall is the rotary chair that Spryson has pioneered. Now, for those at home, and if you're listening and been thinking about seeing Dr. Schneider for his care, what he's about to be endeavoring on is absolutely exciting because now he has a platform that has integrated VNG and eye tracking, video oculography in a rotary chair. So now instead of the person being perfectly still and seeing their volitional eye movements and some reflexive eye movements, now they can be in a chair that is tightly integrated via software, and we can move the patient while getting perfect diagnostics. It's FDA cleared for getting this diagnostic. So it is the pioneer of this. And when research institutions, which we work with many, want to do this type of research, they go to Spryson to make this technology. So now what you have is literally this beautiful model of being able to look at their eye movements, do a visual vestibular examination with the chair integrated with the goggles. And then same thing, if you need to treat the peripheral vestibular system, you have a way to do that. If you have a way you need to treat the cortex, you have a way to do that. If you need to stimulate different parts of the brainstem, you need to do that. And then right in that session, you could do a diagnostic and then find out exactly if you made the right choice clinically and are serving that patient. Now, you spent some time at the masterclass event where Dr. Kitterman and the team of doctors are working with all those patients. Every single case looked like a miracle. Like,
oh, it was so immediately evident with it, because you could test it, you do a procedure, and you look at exactly the improvement that came just like that, just instantly.
I mean, Dr. Kitterman even made the comment. He goes, if we told people that we just made this change and showed them this data, they would go, oh, that's not possible. But it is possible because we're leveraging technology appropriately. And let me add one more thing to the rotary chair that's going to be in your practice this fall, Dr. Schneider. This one is really, really special because there's rotary chairs that have been around for a while, but they've only worked kind of like they work like an office chair. You spin to the left, you spin to the right. But they weren't able to very precisely move people into the vertical canals as well. So we have 6 canals in our peripheral vestibular system. You have horizontal ones, then you have anterior ones, and then you have posterior ones. This platform is capable of doing diagnostics, very high frame rates for all of those angular acceleration canals. And we have tests for the otolithic system. So it is one of those platforms that when you have the integrated VEG and rotary chair, you have such a map of your patients that when you make that decision to say, that's where the problem is, I'm going to work here, and then you train them there and then reassess them, that's when, to me, that is the most fun you could have clinically.
Oh, yeah,
you know,
definitely. It actually was fun. It's like a blast. It was like a lot of fun,
it was a very special weekend with the nicest, humblest, most generous, brilliant doctors I've ever had the opportunity to work alongside. That's what I love about this group of pioneers that Spryson is bringing on. And they have a specific purpose to help us create the best platforms in the world for acquiring data and then doing very specific targeted brain training. There's another element. There's another mission behind Spryson, though. If I could share a little bit about it, Dr. Schneider.
Yeah, go right ahead.
All this data that we're getting, we feel it's going to change the world. You have to realize all this information goes into a database. And in a matter of years, we're going to have millions of data points on different types of patients with essentially a map of their brain function. One day, when you have all that data and you pair that with AI, and then, the clinical acumen of a doctor, that is going to change healthcare in the world. And that, to me, is, as much as I love serving doctors like yourself and I love serving patients, gosh, I get really excited when I think about the impact we can have when I go, wow, the data that we're all getting by mapping these patients' brains, by looking at the visual system, the vestibular system, some of these very advanced tests that we try to make easy on these platforms, what that's going to do in the future, we're going to be able to see diseases and pathology years before they arrive. And I got to tell you,
before they arrive, right?
We're doing that now.
Is really, really fantastic. But a better progression in patient care right now is the most important thing. So we do a basic program of 20 visits, usually twice a week over a 10-week period of time. And we are getting better neurofeedback, QEEG results than we ever have in that period of time. It doesn't mean they have to do 50, 80 visits and they're saying that, I don't get the results. And I already did that. Well, it's not that you already did that. You need to measure it right. You need to proceed with multimodal rehab, and you need to retest, right? And our retests are fantastic. And so the reason we went with Spryson is that we're dedicated to the diagnostic end, but then also the therapeutic. And Spryson combines both. You just don't test. The test leads you into a protocol, that's quick, that's fast, and gets a complete change in the nervous system that's permanent. it's like it's not going to go away. It's not like, okay, go home and then it's all gone by tomorrow. It's not. It's good therapy. And the only good therapy is one that gets you better permanently, not temporarily.
The reason I think what we're doing is so different and so impactful is, if you can't see the things that we can see, and we pride ourselves in being able to capture more data and literally see, I mean, if you did a side-by-side comparison of different reports from different systems, I've done it, you'd be stunned. I literally had one research institution say, well, there must be something wrong with your platform. I see all these lines here. And I go, no, that's what the other system could not see.
You could not see.
That's literally the problem. But if you cannot see that, you cannot make a better decision. So I think what happens a lot, and people that do the type of work that you do, is when their diagnostics is less precise, what they tend to do is throw the kitchen sink at them. Now, I love a multimodal approach to rehabilitation and brain training, but sometimes if you're missing things, you pick 6 things and 2 of them aren't appropriate. Well, when you have better diagnostics, it's like a scalpel. You do exactly what they need, and then you sit back and reassess. You don't have to wonder if they're better or not. And that's when you go, it's not that more is better. It's that better is better. Do you get what I'm saying? Like, if you do the right thing at the right amount, it's just better for the patient. And it's easier on them because they don't have to do these 90-minute treatment sessions. And then they feel wiped out, like they're like, oh my gosh, I've been run over by a car. Some of these things look very simple, though they could be challenging. I mean, it's simple to us, but they could be challenging to the patient, but it doesn't look like a lot. 6 minutes of training, and it has such an impact on them. And that is, again, this never stops being exciting to me, seeing such impactful changes in people.
And it's going to keep developing. And it's going to develop because now it's a basic, like when I wrote after the last master class, I think team approaches to learning is the way to go. And so, I mean, like when I was trained in physics, it was, well, the whole class did the test. You go to the library and you spend days trying to finish the test and solve these problems. And it wasn't about solving the problem. It was about the methodology that you went to get as close to the answer as possible. So when I was in the master class, I felt the same way. I felt exactly the same way. It was like, okay, I'm going on a journey this weekend, and I'm going to get as close as I can to the answers that I'm looking for. Okay. Some of them were answered. Some more questions that I had before. But it's
we created new things that weekend. I mean, we literally, as a team, we created new ideas and implemented them right there with these cases. I mean, we're
together
innovating
with everybody.
It was beautiful. I love the community that we have, and I love the clinicians in there. I think the shift that I'm seeing in the space is it's no more about trying to keep my secret and my secret protocols. There's enough patients for everybody. And there's more patients that need our help than we could serve. So
it's unbelievable. And they're sicker now than I've ever seen it in my 36 years.
So we're finding those people that want to work together, want to collaborate, and realize that if we share, that we all can rise up together and all deliver amazing, incredible care. And, and we're being selective because we don't want people to come in that want to just take advantage of everybody else's generosity. Everybody that comes in, we're vetting people, and we talk to them and goes, hey, we want you to really contribute to this program. If you're serious about becoming a better clinician and you want to do that collaboratively, then we'll talk about what that looks like. And then we'll give you an opportunity to do it with what we feel is the best diagnostic and brain training equipment in the world. And then, we give them a little demo, we bring them up to Pittsburgh and show them what we can do. And usually we do it on them or their spouse, or they'll bring in a patient. And at the end, after a couple hours, they're like, this is unlike anything I've ever seen. Dr. Schneider, I'm excited for you having this in the fall. And I'm going to fly up and I'm going to go see you because I want to see your first couple of days of patients because I want to see their smiles and you deliver the things that we're talking about. That's exciting to me.
Right. Yeah, so do I. So I'm so excited. I'm 67. I think Dr. Kitterman's like 77, and he looks like 57. So, I mean, I think that I'll stay young the more I learn and the more I participate. So, so here's to staying young. Here's to the technology that's driving the industry right now and helping people get better faster and more completely. All right. So, Doc, it was so good having you here, and thank you. And we'll have you on again in the next several months. Okay.
Anytime, my dear friend. Thank you for having me on, Dr. Schneider. I appreciate it.
You're welcome. Have a great day. Bye bye.
Thank you for joining us on My Pods podcast. If you're looking for more support, visit us at hopebraincenter.com or follow our journey on TikTok, where we share daily insights and inspiration. Remember, healing is possible. I'm living proof. I'm Dr. Joseph Schneider, and I'll see you next time as we continue exploring paths to recovery.